मैंने सच्चे हृदय से भगवान
Sir, good evening.
Good evening. Can you hear me?
Yeah, yes, sir.
Sorry, I was unmuted.
But मैं वो सुन लिया.
सुन लिए.
अभी ऐसा सुनने का आदत करना है.
The problem today is that suddenly the resident is saying that his files are corrupted and he is not able to open. But we have got all the photographs, X-rays and other things.
Mhm.
CT scan, X-rays and other things. Mahendra Pal is okay?
Yes.
The problem is that so presentation, so he will just speak all the, but the findings and all he can show.
That is okay, sir.
Still he's trying. We wait for 3-4 minutes.
Fine, sir.
Mahendra,
Yes, sir.
today we have got 3 cases. We have selected 3 cases. The first case means superficial bladder tumor, muscle invasive and metastatic.
Okay.
So in the first, you can discuss little in detail about the histories and findings on whatever you want. But then other cases will be like a repetition. So in brief, we'll narrate history and then you can just, all of you can ask the questions regarding mainly the management. And what
sir,
is
only we can also focus where the generally student make common mistakes.
exactly.
That's all. I think
Yeah.
already we have the same cases in the past, so they can go
Correct.
through those videos. Right,
Correct.
sir. But normally, what candidates do in a presentation, the common mistakes we can point out that. Right, Gite sir and Pankaj sir?
Sure.
Yes.
So Gite and Pankaj, I think that we will, both of you also concentrate more on like their, we are preparing them for the exams basically. Now, this is because these are the repetitions. So we don't want to go into the details of theory part. So we have to train them how to answer in exam.
Perfect.
Is it like, sir, in 10 minutes, how can they ask, how should they ask the history in the OPD, and they can reach one investigation panel and then diagnosis in 10 minutes only? Yeah, 15 minutes maximum.
Yeah.
Sir, Dr. Bakshi is joining. Did you ask him? Gaurang Shah, sir?
Bol.
Sir, Dr. Bakshi
He
is
is joining slightly late.
Pardon?
Okay.
Yeah, he is joining little late. Acha, Dr. Hudedar is, I think he has that. Dr. Gite,
Sir, I have to check it.
just check it. If
उsually रहते हैं.
अगर है तो फिर उनको भी जरा co-host बना दो ना.
देखता हूँ सर.
Okay.
Hiren Sodha sir joined already. Hiren Sodha sir is joined.
Yeah.
Yes, sir, I'm there. Good evening.
Hodedar sir, hai sir. Sir, already Anil Hodedar sir is joined. So we have to make him co-host, sir.
So in 1 minute, we will start then. Okay.
Okay, sir.
Paras, you are ready? Paras?
Sir, before starting, I want to say one thing to all students.
Uh,
In the exam, it is general curiosity, but never try to ask the case, right? Never ask your senior क्या cases है, ऐसे क्या है. Never, because once you know the case, psychologically you will drive the case towards your diagnosis, and then you will make mistakes.
And 100% people will try to do the same mistake.
Yes, sir.
you are right. Your mind is always,
Yeah.
Going in that same direction.
Sir, is it not like that? What you want to know, you will go there. Exactly what you know, you will take it there actually yourself.
Yeah.
True.
नहीं mute है.
Okay, I think we should start now. Hi, Udadar.
Hi. Hi, Gaurang.
Nice to see you. Nice to see you.
Yeah.
Now
After
we
long
expect
time.
quite a lot of input from you. Good. So how is the unit going on?
Quite nicely. There are 4 PGs with me now. Actually,
Per year?
our department is recognized by MCI for MCH. Having 4 students. Last year 2 and this year 2 for MCH.
Fantastic. Very good. Good. We are happy that one more, like after Maheshwari, one more GM site has become teacher.
Yeah.
Good.
Yes, sir. Hello.
Okay.
Yes, sir.
And who are answering today?
So Abhishek, sir, and Ojas, sir.
Okay. Fine.
Abhishek, sir.
Yes.
Yeah. Okay.
Yeah, Paras.
Scenario 1. A 56-year-old lady, housewife, resident of Mumbai with blood in urine since 7 days.
Okay, sir. So I'd like to expand on the history of hematuria, sir. Onset, duration, and progress. Onset is in 7 days, sir. Then, sir, duration is 7 days, sir. Then onset, sudden in onset, sir. And what is the progress, sir? Then I would like to ask about the character of the hematuria, sir. Whether it is painful, painless.
Do one thing, Abhishek. Do one thing. Don't
Yes,
tell
sir.
us. You just ask, and he will answer.
Okay, sir. Okay, I want to know whether the hematuria is painful or painless. Whether it is painless. Okay, whether it is associated with clots or not.
It is associated with passage of clots.
Okay, if yes, then what kind of clots are these? What kind of clots are those?
Amorphous and safe.
Amorphous. Okay, fine. And is it associated with any tissue bits associated with it?
No tissue.
No tissue bits. Okay. Then is the hematuria continuous, terminal, or
Complete.
sorry, complete?
Complete. Yeah.
Complete hematuria. Okay. So then after that, is the hematuria associated with fever or lithuria or anything?
No, it is not associated with fever, lithuria, trauma.
Okay. Any previous surgeries? Any previous history of instrumentation or catheterization?
No.
Okay. Any comorbidities? Any comorbidities? Any history of anticoagulation or anything?
No history of any anticoagulant or bleeding disorder.
Okay. So then, other than that, is the hematuria associated with lower urinary tract symptoms?
No.
Okay. Any flank pain associated with the hematuria?
No pain. It's pain.
Okay. No flank pain. And is the patient diabetic or hypertensive or any other comorbidities?
Patient is hypertensive.
Achha, she's hypertensive. Okay. Not diabetic, right?
No type.
Okay. And does the patient have any? Does the patient give any history of addiction of any sort, especially smoking?
No.
No history. Achha, is there any significant family history in the sense that any first degree relatives have been suffering from any similar cancers or GI cancers, cancer breast or anything like that?
No.
I want to interrupt. You ask similar cancer. Similar cancer is a something wrong word. How do you know she's having cancer?
Okay, right, sir.
Similar symptoms. You can ask similar symptoms. So when you say similar cancer, it shows you are biased. You know the diagnosis.
Right.
And
yes.
here the examiner will catch you. You know the case.
Or
That's
you can
say
any history of malignancy in the.
Yeah.
Okay.
वो उसमें second में आ जाएगा, ठीक है? But this should not ask specifically any history of similar cancer. Similar means you know the case.
Got it. It should.
Okay.
And,
yeah. But
yes,
you ask everything all right. Only thing is the history of trauma was missing.
All right, sir.
That
Sir, then
rest you ask for everything. Yeah. No,
and,
now
any
now
hit-
suppose
any
that
Yes, sir.
Paras is the patient
Yes, sir.
and he's presenting you the history. And you are the
Yes.
physician.
Yes.
Now ask what, now you know everything, the history. Now you ask
Yes.
what you ask Paras, and Paras will answer.
Okay.
Paras, can you just go to the next slides?
Yeah.
The history slide, only history slide. Yeah, that's all. And he has asked you about the other histories also. Abhishek has asked already other histories.
Yes.
Okay, now history.
Metastatic history and history of CKD, I would want to ask also, sir. Yes. So there is no history, sir.
No history.
Why CKD?
Sir, because if there is hydronephrosis, sir, that may lead to renal failure, sir. Yes, sir. So that is why CKD history I would want to ask.
So why hematuria is important? All hydronephrosis has hematuria, or CKD
No,
has
sir.
hematuria?
No, sir. No, sir. Sir, if this hematuria is because of a bladder malignancy which is involving the muscle, which is causing the hydronephrosis, that may cause back pressure changes, and sir, there may be associated kidney failure, sir.
Already you have asked the history of left flank, any flank pain.
Yes, sir. So that was for hematuria and I mean stone also, sir.
Yeah. So anyway, you will come to CKD when you investigate the patient, or if she's a known case, tell you I have known case of CKD.
Yes, sir. And
Okay.
yes, sir. Of course,
What
history of
next?
jaundice, backache, bone pains.
So it should be very focused when you ask the questions. These sufficient. There is no need to ask about the CKD because CKD rarely linked with the hematuria.
Yes, sir.
Right?
I also think so. You're going to some extreme, causing hydronephrosis, kidney failure, and whether both the kidneys will get involved. I think this was unnecessary. If you're doing well, then suddenly you should not make such blunders.
Right.
So I agree, Dr. Hiren, with what happened. Examiner will spend 5 minutes with you only in this topic, and when he will come back to your topic, okay, you will miss something when you come back to your track of this case.
Yes.
Okay. So be focused.
Okay.
Okay. Okay. What after this? What you want to do?
So after this, I would want to examine the patient, sir, on general examination, sir. Sir, vitals. Yeah. Yes, sir. Sir, vitals of the patient
has.
Sir.
Okay, fine.
Yes, sir. Sir, then overall general examination of the patient, any vitals, is the patient febrile, afebrile on examination, sir?
One thing, in female patient, always the history of parity, you should always include that one line.
Okay, sir.
Yeah. Okay, that is all normal. It is fine.
Yes,
Next, Paras, next slide, what is it saying? Yeah. What is asking? Okay.
So yes, sir. In general examination specifically, I would want to see for pallor, sir, and any pallor and any other lymphadenopathy. Lymphadenopathy will not be appreciable on general examination, but pallor I would like to see, sir, definitely.
So what are the indirect signs on this examination that can indicate that may tell you about the lymphadenopathy?
I don't understand the question, sir.
In this general examination,
yes, sir.
What findings can indicate there is a lymphadenopathy?
Can there be some
Pallor?
pressure changes?
Okay.
Something, like
yes,
that?
sir. Yes, sir. Sir, lower limb edema or sir varicose veins in the lower limb, sir. Lymphadenopathy.
See, Abhishek, nobody knows the site of hematuria, whether it is from the kidney, from the ureter. So,
yes, sir.
As a broad sense, you can assume that
yes, sir.
Okay, if it is the pelvis, as Dr. Hiren pointed out very well, can be lower limb edema, maybe venous edema, lymphedema, whatever it is. So these two things may indicate you about the pelvic lymphadenopathy.
Yes.
Retroperitoneal lymphadenopathy, normally you cannot see clinically, but pelvic lymphadenopathy you can see by these two signs.
Yes.
Okay, fine. What do you want to know next?
Sir, then per abdominal examination, sir, I'd want. Sir, in per abdominal
Pankaj, anything you want to add?
Just while giving the examination, you should be very practical. When you are sitting in your OPD and any patient come to you with this complaint, so immediately at the end of 3 years, there are 3 to 4 diagnoses click in your mind. Okay, it may be urolithiasis, it may be GUTB, it may be CA bladder, it may be TCC, upper tract, lower tract, something like that. So while telling the history of present illness, you should tell in one word. One line. Like, for example, diabetes. There is no history of polydipsia, polyuria, polyphagia. That means you are suggesting examiner that you are ruling out the diabetes. Same thing like in urology. If you are expecting, suppose you want to rule out the tuberculosis. So उसमें पूरा आ जाएगा, फिर कफ है, एक्सपेक्टेशन है, ओल्ड हिस्ट्री, पल्मोनरी कॉक्स है, लोअर यूरिनरी ट्रैक्ट सिम्टम्स है, स्टोरेज प्रोमिनेंट नहीं है, ये सब चीजें जो हेमाचूरिया का है, ये सब एक साथ क्लब करके एक लाइन में अगर बता दिया तो एग्जामिनर को लगेगा कि यू आर थिंकिंग अबाउट ट्यूबरकुलोसिस टू रूल आउट द ट्यूबरकुलोसिस. Like history of not passing, not having a lithuria, history of not having any surgery in the past for stone disease, no any instrumentation, no any history of acute urinary retention, ऐसा बोले तो स्टोन का हो जाएगा. इसमें ही सीआरएफ तुम ऐड कर सकते हैं. तो 4-5 लाइन में वो नेगेटिव हिस्ट्री इंपॉर्टेंट हो जाना चाहिए.
गीते सर, हेलो. हाँ
जी सर, बोलो.
सर, हाँ सर, कंजम्पशन ऑफ टोबैको इन एनी फॉर्म, though she is a female,
it is important.
हाँ, though she is a female,
yes,
in
it is
rural
important.
area, they use that this one toothpaste like Mishri, and that contains lot of nicotine, and correct, that is one of the etiological factor in personal this one history.
One more thing, Abhishek, and every resident should, I want to point out that in female young patient who has not reached menopause, there is a cyclic hematuria.
Right.
Yeah.
Cyclic hematuria indicates endometriosis of the bladder.
Endometriosis.
Okay?
Yes.
Yeah. So you should ask always this young female patients. Okay.
Okay.
So in spite of telling history of present illness, one symptoms of this disease, another symptoms of that disease, ऐसा अगर कर दिया तो वो एग्जामिनर भी कंफ्यूज हो जाएगा, तुमको क्या बोलना है पता नहीं चलेगा, और एंड ऑफ द डे को सब कुछ कंफ्यूजन हो जाएगा.
Also, last time Gaurang Shah sir pointed out very well that every female patient you must ask history of menstruation. Many times we have seen patient is confused between menstruation and urine hematuria.
Yes.
That should be ruled out because patient is a female and could have had some mention. So he's mentioned it, menstrual history, but you should have asked.
Right.
So I request all the students to write himself the symptoms of each common disease of urology, and while telling in exam, you should that tell in one line, 3-4 words. That means you are ruling out that particular disease. It will be very impressive. As far as DNB is concerned, examiners are very strict. तो तुमको एक चीज पूछ के टाइम खत्म हो जाएगा.
Yes.
What sir is telling is you should have a protocol in your mind. I'll tell you, I was in University of Amsterdam. They had a protocol. They had something called hematuria clinic. So PGs and fellows would be posted there. Any patient with hematuria comes will have to fill in that entire questionnaire. All these questions that you have asked, everything, followed by ultrasound and physical examination, followed by a cystoscopy, flexible cystoscopy. This is how hematuria clinic used to happen there. So what we are trying to say is, what Gite sir is trying to tell you is that unless you have it in your mind, it will not come in the exam.
Correct.
So that protocol has to be there in your mind. All of you write it, make a list, then we can discuss it. Maybe next class, then we'll know that whether any question is missed or not.
Agreed.
Yes.
Yes.
Fine. Next, go ahead, Paras.
For abdomen examination, inspection abdomen flat, umbilical central and inverted, no visible lump, peristalsis, pulsation, engorged vein or stomach, all quadrant moving equally with respiration, no renal angle fullness noted on either side. Palpation, mostly the per abdomen examination is normal.
Yeah, Paras, just go ahead fast.
Yeah.
So everything is, otherwise everything is within normal limit, correct?
Yes. Yes.
Yeah. So what's next? Abhishek.
Yes, sir. Sir, so I would go ahead and investigate the patient, sir. I do some routine blood
So what is the-
investigation.
Before you go for investigation, just tell us your differential diagnosis.
Okay,
What
sir.
is there
So,
in your mind? If you are
yes, sir.
sitting in a OPD, patient like this comes to you, what are the probable diagnoses? Because your investigation will be based on that.
Yes, sir. Sir, so she's a 56-year-old female with a history of sudden hematuria of, sir, 7 days. So, sir, my first differential diagnosis will be, sir, malignant hematuria because of malignancy, sir. Maybe from the lower tract or the upper tract, sir. It may this hematuria may be, sir, it may be because of a stone also, sir. And sir, thirdly, sir, other than that, sir, GU cox can cause hematuria, but that will be, sir, established GU cox, sir. So that it has to cause hematuria. So that way, sir, yes, sir. My DDs would be this on the basis of history, sir.
She is menstruating
She's attained menopause, I think, sir.
and she's a female.
Yes, sir.
Then anything else can be there. Why there cannot be a malignancy involving the genital system, cervix?
Could be, yes, sir.
Invading-
Sir, yeah, invading the bladder. Yes, sir. Yes, sir.
Fine. Okay. So now next what?
So, sir, further, I would like to investigate the patient, sir. I would do some routine blood investigation, including CBC, serum creatinine, sir. Liver function tests, sir, some centers do, sir, but in our center it is not done, sir. Other than that, sir, urine routine and urine microscopy, sir, and urine culture sensitivity along with ultrasound KUB. And in some centers, they prefer to do a CT abdomen, pelvis, and chest together in one go, sir. So,
Some center is a wrong word.
yes,
Either
sir.
use guidelines, either use
So,
word guidelines.
yes.
Some center they will ask which center.
Yes, sir.
Okay.
So,
So and for hematuria, there is a proper guideline for hematuria. What are the set of investigation you will do?
so yes, sir. Sir, other than yes, I forgot cytology, sir. Sorry, sir. So urine routine, microscopy, urine culture sensitivity, urine cytology, and sir, as per guidelines, sir, contrast and CT scan of the abdomen, pelvis, and the chest, sir.
Directly, you will not do sonography as a initial. Suppose that
Initially-
maybe only USG can be the last diagnosis for her. You don't need
sir,
CT scan.
Yes, sir. Sir, to complete the evaluation of hematuria, sir, CT would be required, sir. So that's why.
Abhishek, you will never go wrong if you say ultrasound. Never.
Yes, sir.
What Dr. Mahendra is trying to tell you, please take a tip from that. Ultrasound is the easiest available tool. PGs do it themselves, and hematuria clinics also have it. Even in our centers in India, also in CMC and all, they do themselves. Ultrasound gives you a lot of information on where to concentrate and what type of CT to do and how to proceed next. It does not harm the patient. It is easily available. It is cost effective. It is a screening tool. The rest of the abdomen also can be screened. Sometimes enlarged lymph nodes can also be found out. Stone disease can be diagnosed. Cystitis can be diagnosed. Female patient extra all the genital tract can be seen. So, lot of advantages. I don't think that you will go wrong if you say ultrasound.
Sir,
Right.
I
All
agree with
examiners
you.
will. Yes, sir.
Hello, Gite sir.
Yes, sir. Yes, sir.
Haan,
Yes, sir.
I agree
Yes,
with
sir.
you.
Hiren, sir.
In Nadyad, we were using ultrasound like stethoscope.
Yeah, I know, sir. I was in Nadyad also for a few months, and it
Yeah.
is routine.
Correct, sir.
It
That
is
is what
routine
I'm
there.
saying, that if the examiner comes from Nadyad or CMC or something and you say CT scan, they will say, boss, you are from Mumbai, that is why you are saying CT scan. You agree, no, sir? All these bigger centers have ultrasound available right in the OPD.
Yeah, yeah.
Correct.
So the take-home message in that, and I think Dr. Hiren, in all classes, he says this thing, there is no harm in saying USG. I remember whatever class I have attended in oncology, well, Dr. Hiren has pointed out this thing, you can say USG as the next generation very safely. Nobody will say, why do you want to do sonography? Okay.
Right, sir.
And I will come to know about the CT scan, why it should be done selectively in the patient who is having hematuria. Okay.
Yes, sir.
So now you said you want to do urine culture, cytology. Okay.
Yes, sir.
And
Yes, sir.
sonography.
Ultrasound of the
Okay.
KOB and the abdomen. Yes, sir.
Paras, do you have these reports?
Read routine microscopy and culture sensitivity and cytology.
Fine. So, okay. And Abhishek asked sonography. Is it there?
So, yes, sonography image I am not having. Printed
Okay,
report.
fine. That is fine. Okay.
Sonography is suggestive of intraluminal polypoidal soft tissue echogenicity focal lesion seen arising from the left lateral wall of the bladder adjacent to left VUJ. And there is a small polypoidal well-defined focal lesion in the mid-pole of particularly medullary junction 7 to 7 mm in left kidney.
Fine.
Yes, sir. Sir, so on the basis of ultrasound, sir, there can be two causes of this hematuria, sir. Most obvious cause is the polypoidal left lateral wall mass in the bladder, sir, adjacent to the left VUJ. And in the ultrasound, sir, I also cannot make out any it is not mentioned about any hydronephrosis on the left side also. There is no there is no evidence of any stone also, sir, although there is a well-defined hyperechoic focal lesion in the mid-pole corticomedullary junction measuring 7 by 7 mm. It is rather small, sir. So I would be more, sir. I think the cause of hematuria is the left lateral wall bladder mass, sir. So, hence I would like to evaluate these things further with the contrast analysis, sir.
Okay. So now question, what are the indications of doing CT scan in patient with CA bladder mass? All patient, because by this sonography, other than having angiomyolipoma on the bladder, and definitely USG is not a diagnostic for angiomyolipoma, and a small calculus in the one kidney. What are the other indications for CT scan in a patient with the bladder mass? In guidelines, there are clear-cut indications for the doing CT IVU CT scan in bladder mass.
Sir, CT scan in a bladder mass will be required when the bladder mass is, sir, a large bladder mass. Sir, yes, a large bladder mass. There may be when there is associated hydronephrosis with the mass, sir. If the mass is adjacent to the VUJ, sir, then a CT scan can be done, sir. Any other findings? Findings noted on the ultrasound that should warrant a CT scan for the evaluation of those findings, sir. So, yeah, sir, in such cases, we want to do a CT scan of the abdomen. And of course, sir, any
cytology is high grade. Cytology is high grade. Cytology, urine cytology is high grade.
Yes, sir. Okay.
Trigon,
yes,
mass over trigon. Okay.
Right, sir.
So suppose that in this case, USG shows only 1 into 1 centimeter lesion over the dome. Okay.
Yes, sir.
And intramural, E by USG, no extensile extension. It is most likely low-grade tumor. Okay.
Right, sir.
So in these cases, you can avoid doing CT scan.
Okay.
So if you know what are the conditions where CT scan can be avoided, these are very few. So most of the places, whenever there is hematuria and you are suspecting a shea bladder, it requires CT scan.
Yes.
In Indian scenario. Usually patient come with 3 centimeter, 4 centimeter, 5 centimeter tumor. In majority time. Once in a while, the tumor is very small, localized to the wall.
Yeah.
If your duplex ultrasound as well as routine ultrasound suggests you it is a very small tumor, not penetrating the muscle, superficial, then that can be avoided. But in rest of the places, wherever the bladder tumor of larger size associated with any complication, like hydronephrosis, large size tumor, any perinephric fat standing, nodes all around, CT scan is required.
Yeah.
Okay.
Agreed,
Right, sir.
Mahendra sir.
Blindly, yes, sir. Fine. I just want to say that don't go blindly. It should be individualized. Okay.
Agreed.
Right, sir.
Agreed, sir.
Okay. At this case, definitely I agree with you because USG is showing me angiomyolipoma, stone, and the bladder mass. I want to evaluate it is definitely the angiomyolipoma or something other pathology.
Yes.
Okay. Other thing. Okay. Yeah.
Most
So now-
important message Mahendra has given that as the case is progressing, you decide. You don't go with that fixed protocol that I will ask for CT. Then you may
Yeah.
go wrong.
Okay, sir.
You have to keep in mind, don't over investigate, don't under investigate.
Right, sir.
Okay.
Right.
Fine. You want CT scan now, Abhishek?
Yes, sir. Yes, sir.
Okay. Paras, do we
Yes,
have
sir.
CT scan?
Yeah, yeah.
Fine. Just you should know how to read CT scan. Okay.
Yes. Yes, sir.
Gaurang sir, should we go deep into the CT scan or just see the reports?
No. Just he should, CT scan at least they should know how to read it. So, in short, he can narrate
Okay.
whatever he's seeing. And then directly in the exam, we can ask them that, sir, this is not a dynamic. So I like to see the report also. So after telling your findings, you can ask for the report. Even in sonography, both. So let him
Yes,
say
Yeah. Okay.
what are his findings, and then we will show him the report. Abhishek, quick.
Yes, sir. Sir, Dr. Paras, can you please go to the previous plates? Okay. Yes, sir. Sir, this is a this is a CT contrast CT scan showing the corticomedullary phase, and sir, the solid organs appear unremarkable, sir. The chest field, whatever is shown, appears unremarkable. No mass lesion can be seen, sir. And other than that, sir, there is a heterogeneously enhancing mass in the bladder, sir. It can be seen at around the posterior wall and extending to the left side. And yes, sir, the rest of the bladder wall, rest of the bladder appears unremarkable. And so the mass does not appear, sir, the mass appears to be arising from the posterior wall, sir, without any pedicle, or appears to be sessile, sir. And
Can you make Anurag Yadav as a co-host? Rakesh?
I cannot appreciate. It appears to be uterus indenting to the bladder base. In this image, I am not able to appreciate bladder mass.
So the problem again, I feel, Abhishek, is that you directly went to the bladder. Again, you should have said plain and contrast enhanced CT scan of abdomen and pelvis, liver, gallbladder, spleen, pancreas, kidneys, uptake, excretion, all these things you have missed out. Great vessels. You're just directly talking about the mass.
So
If it is a long case in the exam, bladder cancer, then they expect you to read everything.
Right, sir.
so there are two ways to explain, Abhishek. Dr. Hiren pointed out very well. Both ways okay. First, you just tell the what area has been covered, contrast not encouraged. So either go disease part first, then normal part, or normal part, then go to disease part. Okay. The only thing is that I always say to any whatever you explain as the sequence. If examiner close his eyes, and when he opens the eyes, he should see the same thing on CT scan, whatever you have described.
Okay, sir.
Right, Dr. Hiren?
Agree.
Yeah.
Absolutely. This is, you should give an overview. Examiner should not get up and go and see the CT. You have described it in such a way that he believes you. That is how you should describe it. And either way is correct. Either you be disease focused, that you're talking about the bladder, but then you should talk about the other things. Now, Dr. Mahendra sir pointed out that your uterus is there. You have not talked anything about uterus, ovaries, kidneys. You were saying some angioma, lipoma, some stone. The plain film is not there. You should have said, I want the plain film to comment on the stone. See, all these small things, if you miss them out in the exam, there may be a stone reported on sonography, but there may be no stone in the kidney.
Right, sir.
And in the long case, all these details are important. No? It's all about the details. Did you miss out anything?
Right, sir.
Now, in this CT scan, can you see mass? I can appreciate mass in this.
Unable to make out, sir.
This is the third image.
Third
from
row,
left side. First row.
Yes, sir.
Yeah,
Yes, sir.
one.
Only that
Can
one,
you
sir.
see
Yes, sir.
This is mass over there.
Yes, sir. Only that much I can appreciate, sir.
Yes. Okay. And over here also, the second in the right row, the second one, second image, the right row. If you have thickening over there, left side of the wall.
Yes,
right?
Sir.
Okay.
Yes, sir. Yes, sir.
Now,
Correct. That is what
somebody.
I also noticed.
Yeah. So somebody in the chat box, I would go ahead with the cystoscopy and proceed with the CT scan. Okay. So do you agree with this management?
Sir was asking to add him on the chat. Sir wanted to talk to him. He has suggested he will do cystoscopy. I think sir wanted to ask him. Gaurang sir was saying to add him.
This is Anurag Yadav from Agra.
Yeah,
Hello.
Anurag, go ahead.
Yeah.
Hello.
I had written that. And,
we
going
know
by
you,
the,
sir.
yeah, going by the indications of CT by guidelines, this small tumor is not. I mean, the CT is not indicated as small tumor in the beginning. So after ultrasound, I would go for cystoscopy, and if it is resectable, I will do a TURBT or just a biopsy if I think it is solid, unresectable. CT will be done later on.
Yeah. Yeah, right. Only the drawback. Yeah, yes, sir. Please, Gite, sir. Please.
There are two ways of thinking or two ways of school. There is definitely a role of CT scan in majority of the CA bladder patient, along with as per with guidelines also. If you do a CT scan posteriorly, that is after your TURBT, you have to wait for some time because there is architectural distortion of that particular wall. That is one thing. If it is a very small tumor, already we discussed that. If it is a very small tumor, yes, CT scan can be avoided. But bladder tumor in near about 4 to 10, probably exactly not knowing the number, 4 to 10%. There is a concurrent upper tract tumor also, so which can be missed by ultrasound. And CT scan helps in many ways because the presence of lymph node, amount of hydronephrosis, sometimes that ultrasound is man dependent. So CT scan is better in going in majority of the patients. Until and otherwise, there is a selective in a patient who is literally very small, a pedunculated small tumor. Then it's whatever the approach, Yadav sir, you are planning, that is good.
Yes. If the patient has to pay for CT scan himself, I would like to wait.
So I think the student should get a proper message at this scenario. If ultrasonography shows there is a doubt suspicion of low-grade malignancy, like single tumor less than 3 centimeter having a stalk, okay, and not in the trigone and are not of the ureteric orifice, absence of HUN, okay, then as Anurag sir said that scopy and TURBT in the same setting can be done. In other setting, like nodular lesion, sessile lesion, and other scenario, CT scan should be done followed by TURBT. Right, sir? Anurag sir?
Yes, yes.
I think this message should be.
Important
This is
thing,
what the guidelines say.
see, the
Yeah,
important
this
thing
should.
is, important thing is in exam, whatever you see, if you can justify. So if you say, I will not like to do CT scan, then you should justify. And if you say, I will like to do CT scan, you should justify. Because examiner, there are different examiners, and what is what is going on in their mind, we don't know. So both the answers should be ready. So if you are saying in particular case that I don't want CT, I will go ahead with the cystoscopy TURBT, you should have an answer ready to justify it. So that is the only thing.
Right, sir.
And remember one thing, always focus your answer. What is the case you are presenting? Then after examiner ask, you do CT in all the cases? Then you say, no, sir, this condition, I will not do the CT scan, and this definitely I will do. But first of all the answer must be focused towards your case, whatever case you have given. Okay?
Right, sir. Right, sir.
Okay, go ahead. Paras, just
Now,
show the report. Mahendra, you want to ask something? Please go ahead.
No, sir. Just I wanted to give this message ki, what we should avoid in the examination and what we should do.
Paras, just read the message report. Paras?
Paras, you have to unmute your Paras. You have to unmute.
Yeah. Urinary bladder is well distended and reveals a small focal polypoidal growth on the left posterior lateral wall measuring 1.5 into 1 into 0.9 centimeter. It is involving the left vesico-ureteric junction without significant proximal hypouretero-necrosis. No obvious perivesical extension is seen. A few sigmoid descending and transverse colonic diverticula without adjacent pericolonic stranding. Tiny angiomyolipoma in the left mid-pole of left kidney. Focal scarring in the upper pole of right.
Okay, Abhishek.
Yes, sir. Sir, now I would want to, I'd like to counsel the patient regarding the condition he's suffering from, and I would want to explain the condition, the options for, sir.
What suffering from?
Sir,
this word is wrong. Suffering is wrong.
Okay.
The CT scan finding. I will explain the patient about the CT scan finding and the possibility of malignancy.
Yes.
Okay. Possibility of malignancy is there. That's why she need this and that treatment.
Right, sir.
Okay.
Yes, sir.
Yeah.
So I would counsel the patient. Yes, sir.
Explain. You are first explaining the patient. Counseling
Yes,
baad mein aayegi. What is it?
Right, sir. So first I would explain the patient regarding the findings of the CT scan, her probable cause for her hematuria, and the need for cystoscopy and TURBT. and what would happen if she does not undergo the treatment, and the further treatment options that may be required in this patient, sir. And the need for intravesical installation also I would explain the patient, and then later on I would want to take the patient up for TURBT and
So
assistance.
in this what should your answer should be? So I will explain the patient about CT scan findings, and she needs TURBT, and based on final histopathology report, I will discuss further treatment option with her. That's all.
Okay.
That's all. फिर जब केस आगे बढ़ेगा, case will go further, we will get HPR, then we will ask you what to be done next. Then you explain about the BCG, gemcitabine, whatever it is. Am I right, Gite, sir? This is how we should go?
Correct. That is right.
Yes,
Okay.
yes, sir.
Yeah.
During
So
the
now-
during the course of examination, examiner may ask something about urine cytology. Then, as this is a small and superficial tumor, there a role of MRI. So these are the things to be discussed parallelly in this particular case. That's what I feel. Mahendra sir.
So, yes, sir. So I can answer this question. In this case, this CT scan finding showing that this is not superior cycle fat is trending. So is there any other way you can find out it is muscle invasive bladder cancer?
Yes,
Abhishek,
sir.
how will you answer that?
Sir, if sir, in this scenario, sir, if I have to find out whether the muscle is invaded or not, sir, I would want to do a MR urography, sir, and find out whether there is muscle invasion or not, sir.
Why then urography? Again,
Or sir,
MR urography.
why you have CT IVU? Why do you want to have MR urography? Now
yes, sir,
your
only
main aim is to identify about the muscle invasion of the bladder by a tumor or not. Okay.
yes, sir.
So just do a MRI pelvis or MRI
Okay,
bladder also okay. So if organ is specific.
Okay, sir.
Okay.
Sir, in this case, should we mention newer methods like, sir, the optical coherence tomography and?
Don't go by the rare thing. You are
Yes,
digging
sir.
your own
Yes,
grave.
sir. Yes, sir.
Okay.
Yes,
If until somebody doesn't ask, don't say these names.
Yes.
Okay. Yeah.
Yes.
So how MRI is this sensitive and specific for diagnosing muscle invasive bladder cancer?
Sir, I think, sir, the sensitivity is 60 to 70%. Specificity is, I think, sir, 50. I'm not able to remember the exact figure, sir.
So in a blanket, you can say blank statement. Is a varied scoring is there, and varied scoring. If it is score is 3, it is equivocal. As score go, it is more to the muscle invasive, and the score is 2 or 1, it is non-muscle invasive.
Okay, sir.
Right. So
Right.
what I have either it's a Pirate 3 or Virate 3. Pirate 3, it is equivocal thing. Both CA prostate
Yes,
and
sir.
CA bladder.
Yes.
Okay, so you can correlate with that and prepare the answer and give answer like that.
Right.
Okay.
Right.
Okay. Now, what will you do after that? And already we have planned. You explain the relative, and you need a patient needs TURBT. Okay.
Yes, sir.
Right. So, examiner may ask which TURBT you want to do: monopolar, bipolar, or by laser.
Sir, this this tumor is involving the left posterolateral wall of the urinary bladder, sir. So, sir, I would want to do preferably a bipolar TURBT or a laser TURBT, sir.
Okay. Why? Why not monopolar?
Sir, because in sir, the bipolar, the connection, the current flows between the two prongs of the resectoscope, sir. Whereas in monopolar, the current flows through the body, so there is the chances of obturator jerk are more in monopolar TURBT, sir.
So your worry, see how you are digging your grave again. Okay. So your main aim is tuberculation or the obturator jerk. What is your main aim?
Sir, resection
What
of the tumor.
objective in TURBT?
Sir, maximal resection of the
tumor.
tumor, sir.
So
yes, sir.
Is there any study, comparative study that prove that laser and bipolar monopolar had difference in the quality of resection?
I'm not aware of the study, sir.
You should
Dekho,
not say all these things.
in the exam, whatever you are doing at your center, you have to tell that.
Yeah.
Majority places, how many centers were using the laser for turbidity?
Very few, sir.
So, so unnecessary you are diverting yourself to some difficult situation. Na? Better you will tell, like I will do a routine
Since you have
monopole.
raised,
Azim,
since you have
Azim,
raised
can
this
you-
topic, we can ask Dr. Pankaj sir. He is here on with us to throw some light on laser enucleation.
Okay.
So you see, the major advantage of full beam laser would be you could do an en bloc enucleation. By literature, they say that the possibility of finding deep muscle in en bloc enucleation is higher. The risk of bleeding will be low, and there will be absolutely no risk of obturator jerks. The only limitation will be it will be very difficult to get a tumor more than 4 centimeters out, because a larger tumor, to get it out through the resectoscope sheath en bloc, you will either need to break it further. So the advantage of doing en bloc is lost. So it is a technique which is suitable for small tumors. If you do large tumors, then you need to either break it into pieces or use morcellation.
So, sir, these are the benefits of en bloc resection.
Yes.
Which can be done by monopolar, bipolar, and laser.
Yes. So the plus point of laser will be that there will be no obturator jerks, and hence the risk of perforation will be negligible.
Why I am telling this? Because majority people will use majority people will use monopolar, sometimes bipolar, and few people will laser. So until and otherwise examiner asks any other way, then only you should tell the laser. If your center is using left and right laser, then okay. It is our protocol. My department use only laser. So it's okay. All examiner will accept that and will ask questions related to the laser. So, but
I 100% agree that the student should talk only of TURBT and not of laser to begin with. And this should be reserved for, are there any advances or anything else that can be done?
And sir, if they have to quote some studies?
There are multiple. We have published one paper in IJU, and there are at least 2-3 review articles which have compared en bloc enucleation to say conventional TURBT.
So Mahendra, do you have any this thing papers on the advantages or the differences between the three?
No. So there's sir, I think that no. If I know how much it is, there's no study comparing monopolar, bipolar, and the laser. But en bloc is okay, but not for the large tumors.
Sir, there are multiple papers for en bloc versus piecemeal, but for energy source, there are probably I have not read any paper.
Okay.
Abhishek, don't get confused. Pankaj, I will do TURBT. I ask just to know which you will do. So you will say whatever you have trained with, either monopolar, bipolar, or laser, and same the disease status. If it's sessile mass, definitely if you get, I think the laser will be not a good option for this, and when we have a CT scan, so it's sessile mass, right, Pankaj sir?
You're right.
Since you have spoken about the obturator jerk, now you are doing standard TURBT. So just explain how all you will prevent the obturator jerk.
So yes, sir. Sir, in standard monopolar TURBT, sir, I would prefer to do in general anesthesia, sir. And I would prefer giving obturator block before starting my resection, sir. So obturator block can be given by sir. I have not seen obturator block being given, sir. But the needle track goes between the adductor longus and the behind the adductor longus, sir. So with the patient in lithotomy position, sir. So there is
Abhishek, sorry to interrupt you, but again you are diverting the answer. Dr. Hiren asked what are the methods where you can reduce the operator jerk. He did not ask how will you give operator block. What are the various measurements where you can reduce the possibility of operator jerk? Right, Dr. Hiren?
Absolutely. You are just deviating and then you're going, become, and then you're also making a comment in the middle, I have not seen. That could be avoided. No?
Yes. Oh, yes, sir.
Go ahead and just explain steps of how you will prevent obturator jerk.
So to prevent obturator jerk, sir, general anesthesia should be given, sir. And other than that, obturator block should be given. And the energy of the pottery should be kept low, sir. And other than that, yes, sir. So these methods I know, sir.
How much low? You are doing TWT 90-60, 90 cutting and 60 coagulation. Okay. Then do you think below this energy you can cut the tumor also in bladder wall?
No, sir, not below this.
Abhishek, you have not discussed some important
and then yes, sir, sir, and
bladder.
Sir, bladder filling, yes, sir, bladder filling. I forgot, sir. Sir,
you cut in some small bouts of current rather
yes,
than
sir, not continuous, rather than.
You know these things, beta. Don't get confused.
Yes,
okay, we are just here to help you. Dr. Mahendra is just helping you. Mahendra sir is just helping you,
yes,
making
sir.
your thought process streamlined. That's it. You are doing well. There is no need to get confused.
Yes, so bladder filling I forgot, sir, and sir, piecemeal cut, sir, not continuous current. That too I forgot. Yes.
So the technical thing I will say, once you empty the bladder, okay, when the bladder is filling, again your inflow outflow should be such a way, inflow should be half and outflow should be full. So the filling, the rate of filling bladder is not so fast. Okay. And as soon as you see the bladder base, your tumor base detected, immediately start taking the deep biopsies, because obturator jerk mostly happens when you're taking deep biopsies. Am I right?
Yes. Yes.
So as you see the resection area and bladder is filling, that is the window period where we can take a multiple 2-3 biopsies. Then again bladder is filled, again empty the bladder and do the procedure. Okay, in this way, whether you have monopolar or bipolar, I found that obturator jerk is very, very minimal.
Okay.
Okay. So, Dr. Hiren, anything you want to add? I think.
Yeah. Suppose in spite of doing all this, Abhishek, if you are still getting the jerk and you are scared about the perforation and you have got already material, then you can just take cold cup biopsies.
Yeah.
From the base.
Okay, sir.
Yeah.
One practical aspect, during cutting current or coagulation, where you get more jerk?
Cutting current, sir.
Why?
Sir, coagulation current, sir, because it is a cutting current, sir, because it is deeper, sir. Sorry,
Okay.
sir, cutting current, sir. Sir, it is deeper, sir. It penetrates the penetration of.
It is 90. It is 90. Okay, that
Yes,
is
sir,
sufficient
already.
to stimulate the nerve from far away. Okay.
Yes, sir.
Yeah.
Sir, can you please explain the inflow and the outflow, sir, thing once more, sir?
Outflow should be on fully and inflow you keep it at half. The TUR sheath is designed in such a way that the inflow is more than the outflow actually. That is why in spite of the continuous irrigation, many times while doing TURP also we should keep empty the bladder. Bladder fills otherwise.
I think Dr. Hiren, they have never observed that the flow of outflow and inflow. They should do that in the ureoscopy.
You know, once in a while I've seen somebody doing a mistake. They connected the inflow to outflow, and then during TRP there was no vision at all. And then suddenly I noticed that look at the arrows. Look at the arrows. If you see, you should take the TR sheet tomorrow in the OT and see. Attach inflow and attach your inflow again to the outflow and see what is the difference in the flow.
Right, sir.
Okay, so what sir is trying to tell you is that if your inflow is full, the bladder will fill very fast.
Yes,
so
sir.
you keep it at half.
Keep it
the
half.
inflow.
Okay,
but keep the outflow on fully. So then relatively the bladder will fill slowly.
Understood.
This question should have come in your mind that in spite of the inflow outflow on, why is the bladder still filling so much? because the outflow is slower than the inflow.
Right.
Okay.
Fine.
So
So now next, Abhishek.
you have
Yes,
done a
sir.
very good TURBT. What do you want to do next, or want to know next?
Okay.
Uh,
Yes, Abhishek,
so-
you have done the TURBT. Now what else you want?
Sir, I want a histopathological report, sir. And
Okay.
Yeah, Abhishek, you didn't instill anything in the OT or a 6
yes,
hours
sir.
after that.
Sir, mitomycin C, sir. Yes, sir. Mitomycin C installation
Why?
immediately. Installation is done in the OT, sir.
Why? Indications?
Sir, indications, sir, mitomycin C can be given in all cases of low grade, intermediate grade, or high grade, sir.
And why? What is the rationale with giving mitomycin?
Sir, it does not prevent it. Reduces recurrence, sir, but it does not prevent. It does not lower progression, sir. So mitomycin C is to be given in
You
all.
should know the mechanism of action. You should know how
Uh,
does it act.
Sir,
And
mitomycin C.
percentages.
Percentage, yeah.
Sir, it prevents. It decreases the recurrence by 20 to 30%, and progression it does not decrease, sir. Mitomycin C.
Okay. But what is the rationale giving mitomycin C or chemotherapy immediately post TURBT? The time frame
Yes.
and time frame where we should give, beyond that it will not work.
So within 24 hours it is to be given, sir. Beyond that it will not work. And sir, ideally within 6 hours it should be given, sir. In our center, sir, it is given immediate post-op, sir. I mean, immediate after the TURBT in the OT only.
So you tell me the rationale, then I will tell you how to answer this question. Tell me the rationale of giving mitomycin chemotherapy post TURBT.
Sir, mitomycin C is an alkylating agent, sir. So, sir, it causes structural changes in the DNA, and sir,
Immediately. Okay. It
no,
prevents
sir.
cell implantation. It prevents protein cells, kills protein, and Dr. Birju ne काफी अच्छा, he wrote very well over it. Same thing, he answered that. Okay.
Right,
This
sir.
is the rationale we give. So your answer when to give. So you should give. It should be given within 6 hours, preferably immediately post-operative period. If there is no hematuria and bladder perforation, okay, 6 hourly, and max to max within 24 hours.
Right, sir.
That's all. In
Right,
one
sir.
line, your answer is finished. Okay.
Right, sir.
Yeah.
Sir, on bladder irrigation, we should, sir, stop during that installation, keep it for 1 hour,
Definitely.
and then.
Yeah.
Right, sir.
So same time, you should not hydrate patient very too much.
Yes, sir.
So that his bladder will fill within
Fill quickly.
half an hour. Yeah.
Right, sir.
And same time, you
Okay.
have to explain the patient whenever he feels bladder is full, he has to tell the staff nurse or doctor so they can release the clamp.
Right, sir.
Right. Paras, show them pathology report. पारस जो बोलते हैं वो बताओ ना.
There are two HP reports. According to the first report, the superficial bladder biopsy and deep bladder biopsy was taken. Fragments show high-grade urothelial cancer with focal lamina propria invasion is noted. Areas of necrosis seen. Deep muscle is not included. There is a second report. Which is suggestive of low-grade urothelial carcinoma of bladder. Occasional foci suspicious of lamina propria invasion noted. Deep muscle invasion is not seen.
So why these two reports, Abhishek?
Sir, probably a re-TURBT was done because in the first report there was no deep muscle that could be seen, sir.
Can you go to the previous report?
So these reports are of two different people, but this is just a scenario brought next to it.
Yeah, I want to go to the previous report.
Yeah.
Okay. So now in this case, how will you proceed? Suppose that you did a very good TURBT and this
Yes,
reporting done by the very good pathologist who is experienced in bladder tumor pathology. How will you proceed?
Sir, I would want to do a re-TURBT in this case, sir, after
Why?
a period. Yes, sir, because deep muscle is not included in the given biopsy, sir, as per the report.
Hmm.
So after a period of 3 to 4 weeks, sir, I would go ahead with a re-TURBT. And
The
yes, sir.
reason due to re-TURBT?
Sir, I want to rule out muscle invasion, sir.
Why?
Sir, if this is an MIBC, sir, my entire management will change, sir.
Something else? Indication of re-TURBT. I'm asking very specific question. If there is a high grade in the specimen and muscle is not included in the specimen, what
High
evidence
grade,
and
yes, sir.
data? What data says?
Sir, in high grade tumors, we must do a re-TURBT, sir, to confirm. And when there is muscle is not included, then also we have to do a re-TURBT, sir.
In exam, you should answer if high grade is present, there is a chance of residual disease of this much. If there is a detrusor muscle is not included in the specimen, there are chances of upstaging in this much of patient. And again, disease is remaining in this much of patient. This percentage you should have in your hand. That is the rationale doing restage TURBT. Okay.
Right, sir.
I think the message is clear to everybody about regarding this. Now coming to the next slide. Okay, now in this report, do you still want to do a re-TURBT?
No, sir. Sir, this is a low-grade urothelial malignancy, and deep muscle invasion is not seen. They have taken deep muscle in this case, sir. So, no, sir. In this case, I would not want to do a re-TURBT. Hello?
Yeah.
Hello? Yes, sir.
Yeah, we can hear you. Tell us.
Yes, sir. Yes, sir. So, this is a case in this slide. This patient is a case of low-grade urothelial malignancy, sir. And sir, deep muscle invasion is not seen. Means deep muscle was taken, sir. So, in this case, I would not want to do a re-TURBT.
No, I can't hear. Why?
Hello,
There is a high sub T1.
Sir, it's a low-grade malignancy, sir. Low-grade urothelial carcinoma of bladder.
I got disconnected. Yeah.
Hello.
Sorry, I got disconnected. Yeah.
Yes, sir.
Abhishek,
Hello, sir.
yeah.
Sir.
Yeah.
So,
Yeah.
Sir, am I audible, sir?
Yeah, you
I
are
can hear.
audible. Now,
Yes,
Anurag
sir.
is saying something. Mahendra, can you explain that? That out of two pathology report, one is saying that it is a high grade, then you should believe it.
Yeah. So, sir, to whom to believe, it depends who is reporting. Okay.
Oh.
So if any person is seeing 5 cases in a year and any person 5 cases in a month, definitely who has an experience, you have to believe on his report. Based on the pathology features, just in first scenario, we have to do a restage TURBT. Now this report, maybe the other case or other patient, if there is a low grade, lamina propria invasion is not is seen. Okay, and even detrusor muscle is not included in the specimen. It is low grade disease. You should not go for the restage TURBT. Okay. So there are the specific indications of doing restage TURBT, like T1 disease, detrusor muscle is absent. Okay.
Yes. Yes.
Now new guidelines, only presence of high grade doesn't warrant restage TURBT. Am I right? So in the patient having low grade disease, lamina propria not involved, detrusor muscle not in the specimen, you can omit doing re-stress TURBT. But if low grade T1 is involved, detrusor muscle is not included, you should do re-stress TURBT.
Yes.
Clear?
Yes,
So
sir.
that's why I gave emphasis to these two reports. Okay?
Yes, sir.
Yeah. गीते सर कुछ ऐड करना है आपको इसमें?
Can I say something?
Yeah, please.
Yeah.
So the second report of histology says occasional foci suspicious of lamina propria. So it can be
Yeah.
T1. Secondly, language of deep muscle invasion is not seen, can be manipulative. It should have been deep muscle is seen, not invaded by the tumor.
So, sir, it is just like the how the pathology use the word. So better in this scenario, we can call the pathologist and confirm with the findings whether he have written like this. Did you see the muscle in the specimen or not? Then we have to
Yes.
confirm on phone.
Yes, and that same slide should be reviewed by the others, because I said in the first pathologist's report, it was the high grade areas seen. So the
Yeah.
same slide
So-
in which he saw the high grade area should be reviewed, not the whole block to be sent to another pathology and he takes in different new sections and then doesn't find any high grade areas. High grade areas has been seen
Agreed.
by a pathologist. If the pathologist is good enough, then you have to believe him. And he was the first choice of the center where you usually send your reports. Then you must believe that. You must see.
Yeah.
If you want to confirm from any other person, you have to send that slide which shows high grade area, not the block. Usually is we send blocks and they make their new sections.
I absolutely agree.
Fine. I think this is a good suggestion. Or we can tell him, okay, first you review the slides which is showing high grade. And if it is not showing high grade, then you review others. Correct?
Majority centers, if the TURBT is done somewhere else, we usually review the slide with our own pathologist. Whatever may be the report. That is one thing. Another thing, there is a muscle or not. Muscle है, muscle नहीं है, clear cut है. Muscle अगर नहीं है तो TURBT करना है. Muscle है और पॉजिटिव है तो कोई क्वेश्चन ही नहीं आता. मसल है और निगेटिव है तो भी कुछ क्वेश्चन नहीं आता. रहता सवाल सिर्फ फोकल एरिया, जैसा ये इसमें दिया फोकल एरियाज, या फिर समटाइम्स ऑलरेडी हाई ग्रेड आ गया है तो व्हाई यू वांट टू डू TURBT. Agreed, Mahendra sir?
Yes, sir. And
is there any confusion?
No, sir, no. And again, one thing important, how confident you are that you have done a good job.
Mahendra, I will.
Majority centers have their own pathologist on whom they believe.
Yes.
Okay. So
Yes, sir.
बाहर का सेंटर में क्या करके आया है वो पढ़ने के बाद में वो usually send same slides. That I agree. Same slides to be sent. So that the report is either confirmed or report can be upgraded or downgraded. So chances of upgradation is near about 11 to 20%. Whenever there is a lot of tumor inside and if you want to complete, then again there is one indication for TURBT. If muscle is negative but you are clinically suspicious of high grade, again there is a chance of TURBT. So there are specific indications. If it is already low grade and muscle is negative, why to do TURBT? If it is already high grade, you have completed, then why again to do TURBT? Because it is already high grade. So that's what. If any changes and new any guidelines, Mahendra sir, please add.
No, sir. Only the terminology, what we use, the difference between re-stress TURBT and re-TURBT. Okay, they are two different things. So re-stress TURBT, when any surgeon does a complete job and based on pathology report, incomplete pathology discussion is there. And when they do TURBT, it is called re-stress TURBT because we are doing this TURBT for proper staging, again proper staging. Okay, so this is called re-stress TURBT, right? And what is called re-TURBT? Re-TURBT means I have done the job. Somebody does a cystoscopy, but there is something tumor remaining in the bladder. I have not done the complete job. ठीक है, that is called re-TURBT. That means removing of the residual tumor. Okay, is it called re-TURBT? So never confuse with this terminology, restage TURBT and re-TURBT. Okay,
Right, sir.
Gaurang sir, आप कुछ बोल रहे थे?
Yeah, I was just telling that sometime what happens is that the person who is taking biopsy, he may not have taken biopsy, deeper biopsy from the center, you know, because of perforation, and he might have taken biopsy from the edge. So in such cases, if you have done a biopsy and if you are not very sure of your biopsy, then I think you should go ahead with the scopy again and to do the TURBT repeat.
Right.
You understand what I mean, na? Sometimes because of the, you feel that you may perforate. So you might not have taken a biopsy from the center. And you might have taken a biopsy from the periphery. So if you've done that, then re-TURBT is required.
I think Abhishek and are you sure you get the point what sir wants to say?
Yes, sir. Understanding, yes, sir.
Okay, fine.
What I mean is that
Okay,
the biopsy, the deep biopsy may not be the representative. So it depends upon the surgeon who is doing it.
Yes, sir.
So if I feel in my mind that no, I have not done a proper, there are chances I will like to go again. Because I thought that in the periphery, if the biopsy is showing muscle invasive, then I will not do rebiopsy.
Yes,
But
sir.
suppose it comes negative,
Yes,
and
sir.
I have got doubt in my mind, I should go ahead.
Right, sir.
Another thing
Fine.
that I would like to add, may I say something?
Yeah,
Yeah,
please.
Yes,
Yeah,
another thing I
please.
would like to add about biopsy is that it is not only two parts, the main bulk and the deeper tissue, but also the margins of the resected area. Because you are not only going to err in the depth of the resection, but also in the width of the resection. So the third bottle should be the margin of the resected area. That should also show negative.
Right, sir.
Fine.
And
Thank
the student
you.
should
Thank you
also
for it.
know.
Doctor, yeah. So
Yeah,
this
the
is the
student
proper
should also
technique
know
of
that.
doing TURBT. Yeah, please go ahead.
Yeah, the student should also know the indications of random biopsies on the bladder.
Yeah, random biopsy and prostatic biopsy.
Prostatic biopsy.
Yes.
So tell Abhishek.
So, yes, sir. So, sir, random biopsy should be taken in cases where
Indication.
cytology. Yes, sir.
First indication. First indication.
Cytology is positive, but cystoscopy is negative, sir.
Wrong definition. Wrong definition.
So then, in cases of
Cytology positive and radiologically no evidence of disease in unit tract.
okay, sir.
And scopy normal. Okay, cystoscopy
negative.
normal and no radiological evidence of disease anywhere in the unit tract.
Yes, sir.
Is it clear?
Got it, sir.
Yeah.
Secondly, sir,
Why scopy is
carcinoma.
important? Why scopy is important? Because CT scan and sonography are not 100% sure about the bladder lesion.
Yes.
Okay.
Yes, sir. Secondly, sir, carcinoma in situ of the carcinoma in situ if it comes, sir. Then thirdly, sir, multiple tumors, multifocal tumors, sir. In that case, we must take random biopsies. And sir, for prostatic biopsies, sir, prostatic urethral biopsies, sir, any tumor in the bladder, in and around the bladder neck, any tumor on the trigone, any obvious lesion seen on the prostatic side, sir, and high grade on cytology, sir. Then also we should take, and then yes, sir.
So okay, fine. Coming to this case, exam
sir.
में people exam में ask कि from the prostatic biopsy, which part you want to take a prostatic biopsy?
Sir, precollicular area of the 5 at the 5 o'clock and the 7 o'clock.
Very good, very good. You should know this thing. Okay.
Yes.
Yeah. So now you have which report you will accept? This one or that one?
Sir, these, you just mentioned these are from two different patients, sir. So I would accept this report, sir, because objectively it mentions that deep muscle invasion is not seen, not that
So
deep.
I think Gite will also agree with me. I will go ahead with the cystoscopy finding during TURBT. What I have seen, okay, and the CT scan finding. Is suppose that it is a solid mass through the whole resection area. It is solid. It is very unlikely to be a low grade. Okay. If I remove the tumor, and in one bite, whole tumor is out, and rest of the resection bladder muscle is absolutely normal, then I will go with this second report.
Okay, sir.
Right, Gita sir?
Agreed, sir.
Yes, very nicely
okay.
placed.
Non-papillary solid tumors, calcifications surrounding multiple red patches. So उसमें clear cut अपना तुम्हारा cystoscopic finding है तो उसमें हाई ग्रेड ही पकड़ना है और जरूरत पड़े तो रेडियोआरबिटी जो भी है वो करना है. वो हिस्टोपैथोलॉजी क्या बोलता है वो, नहीं तो फिर अपने पास अगर नहीं किया है तो अपने पास रिपीट करना है. आंसर इन एग्जाम इज इफ दिस TURBT इज नॉट डन इन एट आवर सेंटर then we will repeat the report as well as if required by biopsy.
Right,
okay,
right,
fine. Okay, so you have done a very good job, and the base of the report disease came as a focal T1 high grade, detrusor muscle not involved. Okay,
right, sir.
Now what will you do next?
So in a case of focal high grade tumor, sir, with the detrusor not involved, that makes it a high grade NMIBC, sir. Sir, so I would explain the patient regarding the need for BCG installation, sir, and the regime of BCG installation.
Again, answer should be adjuvant treatment.
Okay.
Patient
right,
needs adjuvant treatment that will reduce the recurrence and the progression.
Yes.
Okay. And
yes, sir.
in this, intravesical BCG is the standard of treatment at present.
Yes.
This is your
sir.
answer. Okay,
Okay, sir.
okay.
Yes, sir.
So what are the contraindications of BCG?
Sir, contraindications of BCG is in the immediate post-op period, sir. Any incidence of traumatic catheterization?
Why? BCG you can give intraoperative
Hello,
it's
sir?
a logic question, na? Mitomycin you can give immediately post-op period, but BCG you cannot give. You should not give. Why?
Sir, BCG systemic absorption causes sir BCG.
What type of vaccine it is?
Sir, sir, it is a live vaccine, sir. So
live attenuated vaccine.
Live attenuated vaccine. Yes, sir. Live attenuated vaccine.
So what will happen?
Sir, it may cause tuberculosis in the patient, sir. On
systemic.
If it is,
it may cause
systemic dissemination of the disease, sir.
Yeah, that is the answer. Okay.
Yes.
Okay.
Yes,
first ho gaya. Baki, what are the other contraindications?
Secondly, contraindications, sir. Traumatic catheterization, sir. Any hematuria, sir. Any UTI, sir. And if the patient is active UTI, sir. If the patient is incontinent, sir. And if any previous history of BCG sepsis, sir. So these are the
so in general, if somebody asks you about the contraindication, you divide into two parts: absolute and relative. ठीक है? Make a general rule. किसी भी they ask any contraindication or indication should be absolute and relative indication contraindication. Okay, fine.
Yes, sir.
So what is the ideal time and dose to give BCG?
Sir, ideal time would be, sir, 4 to 6 weeks after TURBT, sir. and the dose is 80 milligrams of the Moscow strain, sir.
Okay, 80 milligram of Moscow strain.
For
So
installation, yes, sir.
why do you want to go ahead with 80 mg, conventionally 120 mg? And why only Moscow strain? Why not the Danish strain? There are 13 strains available in the market. Why only Moscow strain? So again, you unnecessarily use the strain word. These things are controversial.
Okay.
The strain part is controversial at present. Okay.
So examiner will ask what are the other strains.
तुमको नहीं पता होंगे. You don't know the other strains name. There are 13 strains, right? 13, 14 strains all over the world, and having a different coliforming unit in all the strains. They have different dose. Some has 10 mg, some has 40, some has 30, 27 mg, like that. Okay. So don't go into this controversial thing until it is asked.
Right, sir.
And about the dose, always go with the conventional dose.
Right, sir.
Okay. Now
Right.
give me the answer.
So, sir, the ideal time would be 4 to 6 weeks after TURBT, and the ideal dose would be, sir, 120 mg, sir, for installation. Yes, sir, in 50 ml NS, sir, normal saline.
Okay. Okay. Again, you have to complete the answer, sir, with the 6 induction doses and
okay, the regimen. Yes, sir. Yes,
induction and maintenance dose. You have,
yes, sir.
You have to finish answer in
Okay,
these two lines.
yes, sir.
Finish it.
So, sir, yes, sir. So, sir, the induction doses are six weekly installations, 1 week apart, followed by a recystoscopy at the end of the induction phase, and then followed, if the cystoscopy is negative, then followed by, sir, the maintenance phase. For the high grade disease, sir, the maintenance doses continue for 3 weekly cycles, sir, at 3 months, 6 months, 12 months, 18 months, 24, 30 and 36 months, sir. That is for the high grade, sir. And yes, sir, that is the regimen, sir.
And what or only high grade for intermediate risk?
So for intermediate, it is given at 3, 6 and 12 months, sir. 3 weekly cycles means, yes, sir, 3 weekly cycles, sir.
So it's a simple way for intermediate risk induction plus maintenance for 1 year.
6 plus 3, yes, sir.
That's all. And for high grade or high risk, not high grade, remember that it will be high risk disease, risk certification, high intermediate risk disease, not high and low grade.
Okay, sir.
So for high risk disease, high risk, it is induction plus 3-year maintenance. That's all. Okay. What is the latest guidelines the Dr. Lamb has introduced recently, 2-3 years back?
I'm not aware, sir.
Okay. If 3 years there is no recurrence and patient tolerates BCG very well, continue annual maintenance. Continue annual maintenance for 5,
yes,
6, 7 and 10 years.
Okay, 10 years.
Right.
Got it, sir.
Okay.
Yes.
So what is the message till now? When you have a biopsy report, you have to stratify the bladder cancer NMIBC into low, intermediate and high risk disease, and then based on this certification, you have to start the intracycle therapy. Low grade, no further therapy, right? For intermediate high risk disease, you have to give intracycle BCG therapy if patient tolerates. Okay.
Yes. Yes.
Clear.
Yes.
Fine. Okay. Gaurang sir, should we go till the BCG failure, other thing all in deep?
No, see, earlier also we have discussed all these things. So can we just fast? We can go for a second case.
Yeah, chalega. Yeah.
Or you
I
want
think
to
that
complete
we
today, and next time
detail.
we can go. If you want to go ahead with the discussion, we finish it today. Only this case, and next time we do another 2 cases.
I think, sir, if we go finish this case in another half an hour, so it will be complete sir, NMIBC.
Okay.
Is it okay?
Done. Next time we'll do other 2 cases. Fine.
Right, Pankaj sir, Gite sir.
Yes. So what is the benefit of giving the BCG?
Sir, recurrence and progression both are reduced, sir.
That is general statement.
Abhishek, you are, I agree with sir. You are using too much general statement. Whenever you say, you have to say some data with you.
Okay, sir, 20 to 30% recurrence and 20 to 30% progression are reduced in BCG, sir.
No, please, proper batao. This is nobody will accept. Always remember, Abhishek, recurrence, progression कभी same नहीं हो सकते.
Okay.
समझ रहे हो? For recurrence, for remember, ये चीजें, I think every student should remember this thing. Please remember or write down this data while preparing your case presentation. This is very important.
Right.
Yeah. So you should know this the evidence about it. Okay.
Yes.
So Mahendra, you can just enlighten them. What is the thing?
Sir, approximately 40% progression is avoided with the BCG, and up to 70% recurrence data reduced compared to mitomycin C. These are the data. Okay, data has been compared with mitomycin C. So that's why in adjuvant setting, intracycle BCG is better than the mitomycin C.
Right. Okay. Thank you. Yeah.
So, what precaution will you take while giving BCG, and how will you optimize the effect of BCG?
So the precautions are before doing a BCG, sir, I would do a culture sensitivity report of the patient, sir. Rule out UTI, sir. Urine routine and
every BCG installation. You are doing weekly. You are doing weekly induction therapy. So every week you will do culture sensitivity.
No, sir. If there are symptoms, sir.
So before starting induction therapy, you do culture sensitivity, and in further cycles or further dose, if the patient is symptomatic, only then you will do culture. Otherwise, not required.
Right, sir.
Okay.
Sir, before the installation, UTI is ruled out, sir. Then before installation, I would have asked the patient not to take lots of fluid, avoid caffeine, sir. And yes, sir.
When will you instruct? When you meet when you are going to put BCG, or you will instruct maybe something differently?
6 hours.
You want to advise plenty of oral fluids prior, or you want to reduce his oral fluids?
Reduce his oral fluids, sir.
At least 6 hours.
6 hours.
6 to 8 hours.
6 hours. Yes, sir. Yes, sir.
Okay.
And then, sir, after the installation, sir, once the patient voids, sir, the urine should be discarded properly, sir. The toilet should be bleached, sir, and all the disposables that have been used should be discarded properly, sir.
So this you told pre and post installation, right? What about during installation?
During installation, sir, traumatic catheterization should be avoided, sir. If any trauma occurs during catheterization, installation should not be done, sir. And other than that, sir, after, once the installation is done, moving the patient, some people advise, sir, but the evidence does not support anything, sir, that moving the patient will help. And other than that,
what moving?
Sir, changing the position of the patient.
Yes. Two things you miss: minimal use of jelly. Okay, because if you put excess amount of jelly, the vaccine will clump around the jelly only, so it will not disperse in the bladder. Okay.
Okay, sir.
And second thing, under gravity installation,
okay,
you should not apply force while injecting the BCG.
Yes. Sir.
Okay, these two things are important. Okay, so this is
Yes.
where you can optimize the BCG this thing effect. Okay,
Yes. Sir.
fine. So after
indication
giving
for
a fifth, yes, sir.
indication for repeat induction course.
Okay, sir. Sir, indication for repeat induction course, sir. It can be given in BCG refractory cases, sir, where although sir, only a single reinduction is advisable, sir. High grade tumor appearing within 3 months or at 6 months or at first maintenance, sir. First is that, sir. If CIS appears within 3 months and persists till 6 months, sir, then it is given, sir. And high grade tumor during BCG maintenance therapy, then sir, reinduction is advisable, sir.
गीते सर
पूरा कंफ्यूज कर दिया उसने.
Yes. So
it is
so the whatever
low grade recurrence अगर है या फिर disease recurrence after the disease free period of 1 year या persistence of CIS, so इसमें repeat induction course करना चाहिए, ऐसा मुझे लगता है. बाकी महेंद्र सर ऐड करेंगे.
सर इसमें जो दो आपने पहले का बोला कि recurrence of low grade disease and recurrence after 1 year, that is indicated, but in presence of CIS, it is to be given those patients who refuses cholecystectomy, because if recurrence is carcinoma in situ, that makes them very high risk, and for very high risk disease, the first treatment offered should be the cholecystectomy. If they refuse that surgery, then we can go ahead with the intraocular BCG, reinduction and everything.
And if I am not wrong, it is 40 to 60% response rate है उसका.
Yeah, right.
Yes, sir.
Right.
Second induction.
I agree.
Yes.
Yes, that you have to tell the patient कि ये induction है, but other option is there. Okay.
Right.
So as you were already defining about the BCG failures. Okay. So definition you should know what is
Yes,
what is it, and
So-
the treatment options all very well known. They're very straightforward. BCG failure, refractory, and relapse. The first option is the
Unresponsive.
early cystectomy. Okay. So suppose that if anybody refuses that I don't want cystectomy, what will you do? And you know BCG recurrence was BCG refractory है, failure है, तो BCG won't work further. What will you do?
Sir, if a patient is refusing cystectomy, sir, then I will give him options of bladder preservation strategy, sir. Means, sir, it can be, sir, installation of other agents, sir, chemotherapeutic agents, sir. Trimodal therapy can be advised to the patient, sir. And other than that, sir,
Like what?
Trimodal therapy, sir.
What therapy? What is it?
Sir, trimodal therapy, sir, involves, sir, maximal tube. Yes, sir. Yes,
Go ahead.
Sir, so trimodal therapy involves, sir, maximal TURBT and chemoradiation given together, sir. So it may be given in 2 courses, sir. First of all, it can be either continuous course or, sir, it can be split course. So in sir, for trimodal therapy, sir, first maximal TURBT is done, sir. Thereafter, in a split course therapy, sir, chemoradiation of 40 gray is given. Then reassessment is done, and if it is progressive, then if the disease is progressive, then radical cystectomy is advised. Otherwise, if the disease is regressing, sir, then the remaining chemoradiation of 64 grays is given, sir. Whereas for yes, sir, for continuous therapy, sir, entire chemoradiation is given in one go, and assessment is done after 6 months, sir, of chemoradiation.
Okay, fine. I am very much impressed with the way whatever you say, that your knowledge. Okay, but I will ask one question only. Dr. Abhishek, what are the evidence in NMIBC temporal therapy?
Evidence for trimodal therapy in NMIBC is usually not preferred, sir.
So why are you offering patient this therapy? Because you know you will offer?
Because, sir,
it would have a better option. A better option like that, I will offer rescue therapy in post-BCG failure.
Okay, sir.
Okay. Rescue intravesical therapy or systemic therapy. Okay.
Right.
Don't go temporal therapy at this stage.
Right.
Evidence maybe are evolving, are coming, but at present you should not use temporal therapy until examiner is asking you, Asha, what else? You have told everything about the other rescue therapies, and he's asking what else? Then you can say as a last option.
Better you should have talked about therapy and HIVAC.
HIVAC, yes, sir. HIVAC and electromotive drug administration.
So,
yes, sir.
That is I am asking this thing. After the BCG failure, what are the other therapies you will offer?
So, yes, sir. Rescue chemotherapeutic agents, sir, intravesically.
Rescue we give normally, but you should not say rescue therapies. You can say other alternative treatment regimens are. Okay?
Okay. Okay, sir. Sir, yeah. Other agents include sir, docetaxel, thiotepa, and mitomycin C can be given, sir. Yes, sir.
अभी तुमको हिंट भी दिया गीते सर ने.
अरे सीधा सीधा बोल दो ना यार. डोज देखो, इंट्रावेसिकल केमोथेरेपी, इंट्रावेसिकल इम्यूनोथेरेपी एंड हाईवैक. सो केमोथेरेपी डोसीटैक्सिल एंड जेमसिटाबिन. कितना डोज है? 1 ग्राम जेमसिटाबिन है. 37.5 मिलीग्राम का डोसीटैक्सिल है. इम्यूनोथेरेपी में क्या है? पेम्ब्रोलुजुमैब है, निवोलुमैब है और मेरे ख्याल से डरवेलुमैब है. अच्छा, 3 इंट्रावेसिकल इम्यूनोथेरेपी. हाईवैक में क्या है? कितना डोज देते हैं? दो चार लाइन परफेक्ट बोल दिया ना तो एग्जाम में ज्यादा डीप जाएगा नहीं. तो शुरू में गड़बड़ कर दे तो पूरा उधर ही अटक जाएगा.
Is it good to have knowledge, but it is best you know when to use it?
देखो, what is the role of radiotherapy in BCG failure as an alternative to cystectomy?
Yeah, sir. I mean, radiotherapy alone has no role, sir.
Is there any studies? कुछ है क्या?
Sir, guidelines में guidelines है no, sir. उसमें radiotherapy alone.
Guidelines में only few studies are there. Guidelines में नहीं है. महेंद्र सर बोलो, आप बताओ.
सर, जो स्टडीज हैं रेडियोथेरेपी के ऊपर NMIBC में, they were saying having good result. Okay, but अभी we don't have that strong data कि we can offer as in this thing. We can say no, it will benefit. A very small series.
They were adding the radio sensitizers nowadays.
Yeah.
Along while giving the therapies.
Normally cisplatin is given for that, but again, in NMIBC and in carcinoma C2, they don't give a radiotherapy. Okay.
True, sir.
Fine. Sir, Gaurang sir, कुछ और रह गया NMIBC में?
No, just if you are completing BCG, then the complication, just finish it off.
Yeah,
and
yeah.
When you will stop, you will not give further.
So, tell us about BCG toxicity and how will you manage?
So yes, sir. So the BCG toxicity as per WHO has been graded into grade 1, 2, and 3, sir. Sir, so grade 1 are mild symptoms, sir, mild dysuria frequency, and sir, some literature mentions mild hematuria also, sir. So in that case, sir, the treatment given is sir, antipyrate. I mean, symptomatic treatment is given, sir, in grade 1 BCG toxicity. Secondly, sir, in grade 2 BCG toxicity, sir, high grade fever persisting for more than 48 hours, and hematuria, sir, and disturbing frequency along with
इसमें इसमें एक चीज ऐड करना, grade 1 disease में you should add one line. When symptoms subside, patient can be restarted CGA, can be restarted again in this patient.
okay, sir.
Grade 1 toxicity, remember. Okay, grade 1 only. Okay. Now coming to grade, now tell grade 2.
So grade 2, sir, high grade fever persisting for more than 48 hours, sir, and hematuria and intractable frequency, sir, lower urinary tract symptoms, sir, amount to grade 2, sir. And sir, treatment given is, sir, we first of all stop the installation, and then when symptoms subside, sir, then reinstallation can be started at a lower dose, sir. And other than that, sir, isoniazid and rifampicin is to be started, sir, along with the treatment given in grade 1, sir, for fever and this thing, sir, fever and frequency, sir. And grade 3 is, sir, all symptoms of grade 2 along with solid organ involvement, sir, means prostatitis, sir, seminal vesiculitis, and those things. So that amounts to grade 3, sir. So that warrants for a stoppage of installation, admission of the patient, and starting full course of anti-tubercular drugs, sir.
And switch over to alternative therapy.
Switch over to alternative therapy, yes, sir.
Okay.
Yes, fine, sir. And I don't know, some literature also mentions a grade 4 as generalized BCG-itis. I'm not sure about that, sir.
It is all comes in grade 3, where patient need admission, epidermolysis, osteoarthritis, everything is in
yes,
grade
sir.
3.
Okay.
Okay, fine.
So any other intravertical therapy you want to ask him, just in short, enumerate what are the different ways,
sir,
all latest.
Sir, only thermo-regulatory things are there already. Gite sir has mentioned that high wake and this thing electromotive therapy already there. It has been, but again, guideline says that this therapy should be offered only in clinical trial setting. Okay.
Yes. Yes.
No, because nowadays they are coming and they are giving it on higher also. So what is the role? If the protocol says that if I'm doing once in a while, is it worth doing, or it is advisable to do, or I should not do it?
It is alternative to radical cystectomy, and in case of the BCG unresponsive muscle invasive cases, so HIVAC can be tried, and usually 5 doses will be given. That is in short about HIVAC.
Okay, fine. So Gite sir, anything is left behind? Hudedar is there if he wants to comment anything. And Anurag ji, if you are there, you want to add anything? I think then to next time we will not go much in history, Mahendra, because we have completed this time. We'll directly go on a management of both the cases, correct? Yeah. And if you have got some, Mahendra, if you have got some cases, like that CA penis, if you have got some multiple cases, just for the management, if this is a case, how will you manage? Just like, 5 minutes or 2 minutes. If you have got a multiple cases, next time, please let us know. So we have got 2 more cases. One is a muscle invasive and second is the metastatic. Initially muscle invasive, but later on it became metastatic. So we have got these 2 cases. We'll discuss in short. And if you have got multiple cases, just show them to students. Okay.
Okay. So sir, we planned a 2-hour class, 2.5-hour class. 1 hour we'll finish MIBC and metastatic bladder cancer, and next half hour we will finish CA penis cases. Fine.
No, not CA penis. CA penis we have done. You remember in CA penis we had multiple cases.
Sir was giving example कि आप जो cases लेके आए थे ना महेंद्र भाई, वैसा sir you can present scenarios of bladder cancer. Sir is saying your cases.
If you have got multiple cases, like in this case, what you'll do in different cases. So like small management So they,
Okay.
they come across multiple cases. So in exam, any
so
different
you-
scenario is given, they
Right.
are able to answer.
So you want to make it like a rapid fire, where I will
Rapid fire.
present
After,
5-6
yes.
cases and
Yes,
rapid
yes.
5 minutes we can finish all cases. Okay.
Yeah,
Okay. Fine.
Okay.
fine.
Abhishek,
Okay.
That is okay.
Yes, sir.
today you are not in good mood.
आज बहुत जलेबी खाया सर.
शायद पता नहीं, लेकिन कूल माइंडेड नहीं था आज. हैप्पीजार्ड काम चल रहा था.
Sorry, sir.
But at least we are happy that sir he is always taking initiative. Others are not.
But
Yeah.
that he will get, he will only get benefit of that.
He will benefit, sir. Yeah, he will
So I
benefit.
request,
Yes.
Dr.
request-
Gite, we should request all the students, please
same
give your name and
Same thing.
answer. Now
Same
only
thing, I am-
few days are left.
I request all the students, this is the only platform you can do a mistake and you can correct the mistake. So please come forward and try to answer the questions.
Yeah.
Acha,
Okay.
how
Right,
will you
sir.
follow the patient? Yes, sir, follow up, Ragya, follow up.
Okay, follow.
Yes, sir.
Yes, sir.
Yeah.
Sir, follow-up for low-grade patients, sir, low-risk patients, sir, follow-up is done at 3 months, cystoscopy at 3 months, then later at 9th month, and sir, then yearly follow-up with cytology, sir. And
No. Low grade, no cytology. Low risk patient,
low-risk patients,
only
sir.
cystoscopy. Low risk,
Okay,
only
sir.
scopy.
ठीक है.
So
Okay, sir.
for patient having low risk disease, cystoscopy in 3 months, 9 months from date of TURBT, then annually for 5 years, then he can be free from the follow-up.
Free from care, yes,
ठीक
sir.
है?
Yes, sir.
Okay. What about
Yes.
intermediate and high risk?
Sir, intermediate and high risk include imaging every yearly, sir, along with this, sir, and cytology is included at 3 months, 9 months, and then along with imaging,
No.
sir.
No. याद करो इस चीज को. A high intermediate में it is 3 monthly for 2 years.
3 monthly cystoscopy
3
and
monthly.
cytology for 2 years, followed by
All-
6 monthly for
All
the
mathematic
next.
है अभिषेक.
Yes, sir.
Everything is mathematic. बस तुमको फॉर्मूला बनाना है हर कैंसर का अलग अलग. You have to make formula of all the cancer follow-up. Okay. 3 monthly for 2 years, annually imaging, and then 6 monthly, and after 5 years annually. After 4 years annually. That's all.
Okay, sir.
ठीक है?
Yes.
It will come slowly, but if you make it like a formula wise, you will never forget that.
Right, sir.
ठीक है? So now I think sir, अभी it is completed.
Okay, fine. If anything is left, next time you can just edit. Okay, so meet
I
you,
will
all
see
of you.
what white left today.
Yeah, see, well, later
Yes,
on
sir.
you may come across something which you have read or you are practicing something which we are not doing.
देखो, in exam, like if as like today there is a controversy regarding the indication of CT scan. In such situation, whatever is happening around you in various hospitals, that will be your answer, or in your own hospital. Okay.
Yes, sir.
So
Yes,
guidelines, different guidelines says different things. NCCN will say early CT scan prior in all cases. Then EUS says it is in selective cases. AUS says again in selective cases. So different things, different guidelines, different type of things are there. So तुम्हारे particularly if examiner asks EUA guideline, what is the as per the EUA guidelines, then you must have tell that. Otherwise, it is always better कि whatever you are doing at your center, this is our routine protocol, sir. We are doing sonography first, later on by it is CT scan. If in that time, if examiner asks it is very small tumor, 1 centimeter by 0.9 centimeter, why there is need of CT scan, then you have to accept the whatever examiner is saying. And in such type of cases, it can be avoided. That will be the way to escape the things.
okay, sir.
Yeah. So take Dr. Gite's advice. He has been examiner for like, he countless times. So he knows different examiners and he knows the
Yeah.
students how they are answering. So take a hint from him and get prepared.
नहीं नहीं सर,
Okay, Mahendra, thank you
कहना
very much.
इतना है कि कहीं अटक नहीं जाना चाहिए, एक बार
Yes,
अटक
yes,
गया
sir.
कि फिर निकलता नहीं।
Yes.
Or one more one point. Whatever examiner asks, please be specific. Don't
Yes.
try to show your knowledge until it is indicated.
Agreed.
Yeah.
Okay. Otherwise, unnecessary word. He will divert the case, and you will be in trouble.
Right. Sir.
Fine.
Okay.
Okay.
Good night,
Okay.
Gaurang sir, Gite sir,
Okay.
Pankaj
Good night,
sir.
sir. Sir.
Yes,
Goodbye,
bye,
goodbye.
bye. Thank you, all of you.
Yeah.
Thank you,
And
Gaurang sir. Thank you,
Udedar
Mahendra
sir.
sir. Thank you, Gite sir. Thank you, Hiren sir.
Okay.
Thank you, Maheshwari sir.
Yeah.
Well done, Abhishek.
Good
No
night.
more
Thank you,
jalebi,
sir.
sir.
Yes, sir. Thank you, sir.
I found Dr. Hiren. I found
Yes,
him
sir.
more confident.
Yeah.
Right. At least in oncology now. Because I have just seen
Of
in
course,
oncology,
of course.
but he's
All
Thank you,
becoming
thanks to you,
confident.
Mahendra bhai.
Yeah.
Thank you, sir.
Thank you. Chalo. Okay.
Bye. Good night.
Okay.
Good night.
Bye.
Sir.
Good night, sir. Good night.